Afternoon, everybody. We're just going to give it a minute or two to let people join before we get started. Good afternoon, everybody. We're just going to give it one more minute and then we'll get started. All right, we'll go ahead and kick it off. Thank you all for joining today. We're here to talk about our FQHC alternative payment methodology cohort 2 application process. Just going to start with kind of a little bit of intro on the APM itself, and then kind of walking through this document that is shared on the screen, which is our application instruction document for cohort 2, as well as for any 1A or 1B clinics that would like to add or change the structures they have in the program. So first, the FQHC alternative payment methodology is a program developed to move away from the PPS structure in a world where we're still stuck with having to, base everything on the PPS structure. So the idea is that sites that apply would have all of their assigned member utilization projected for a specific year. In this case, calendar year 2026. And based on your current PPS rates and the estimated amount of utilization in that period, we would direct the managed care plans to pay the participating site a per member per month payment for each assigned member that would account or get roughly equivalent to what we would project a site would make under the PPS system. Now, the APM then allows the site to utilize that kind of base level of reimbursement to provide services that are not traditionally billable under PPS, or have providers that are not traditionally eligible for PPS reimbursement to provide services. This allows more flexibility and can lead to what we would expect to be more appropriate care for the member, rather than just having to always make sure that a PPS eligible provider provides a service. It's a little bit about the program. Hopefully if you're here, you already have read a little bit. We will be sharing all of this information to the registered attendees after the webinar, as well as we're recording this webinar that will be posted hopefully in the next week or so to our website, as well as all of this documentation being available on the website. So now I will walk through our instructions, kind of high-level timelines on everything, and get everybody familiar with what we are looking for. And then we can open it up at the end for questions, and if not, we can end early. So this is the instructions for the application, not the specific application itself. We are looking to have all of this information sent back to us in order to apply for the program by December 16th, 2024. So this kind of is the kickoff, with all the documentation being released through email, as well as then posted to the website. There's if you were a site that applied for our cohort 1, things are a little bit different now. We are adding a little bit more information, so definitely would recommend that if you had applied for before, that you go through this or reach out to me to kind of talk through that process again. I'm going to scroll down here to our deadlines. So this is today. We are announcing the timeline, the process, and summary for changes, as well as we will be releasing through email this information. One of the big steps, and we'll talk about this as we go, is that for this round, DHCS is requiring the FQHCs to work with the MCPs to have a roster of assignment submitted for all of the sites that you are requesting to participate in the program. This will help us have a more robust screening process and provide eligibility of a site in the program a little bit quicker and, I would say, more thorough than our prior process, which kind of stretched out these 2 steps. So that will be we're recommending that the FQHCs request NPIs and RAP percentages as well from DHCS. I guess 2 of the big pieces for this program are a RAT, which we'll kind of go through later, will be your RAP claims compared to the managed care reported data to make sure that those things are in alignment, and we're requesting that the FQHCs request that. Like I said, we'll go through DHCS through this period, and we can provide you with that amount before you send in your application, so that way it can kind of prevent maybe some work if your percentage is too low. FQHCs are going to have to reach out to MCPs regarding their NPI participation in the APM. So all FQHCs must talk to their MCPs. There's a whole process to get buy-off. We'll kind of walk through that. We request that starts October 1st because you're going to need time to establish that relationship and figure out all the pieces that you need to get done in order to submit your final application. We ask that in October and November that the FQHCs and MCPs work on the rosters to make sure that they're in alignment. The MCPs will be sharing the rosters with the FQHC before submission to DHS to make sure everybody's on the same page. The last day for FQHCs to request assignment rosters from the MCP will be November 20th. There is a lag between when the MCP gets your request and their ability to put together the file and submit it to DHCS. So we're setting that kind of deadline to make sure that the FQHCs are reaching out and not doing any last minute requests to the MCP, which may not get fulfilled and submitted by the December 16th deadline. As you can see here, applications are due on the 16th. Rosters from the MCPs are due with the parent and intermittent NPIs as appropriate. And then there's also the parent and NPI, intermittent clinic NPI crosswalk from the FQHCs that will be due that day. So all materials due on the 16th. As part of the process for this year, we will be doing short interviews with all of the applicants to kind of just walk through some outstanding questions or concerns on our side, requests for more information. This process was more informal in the first application process, so we are making it defined and providing a timeline for that, which will then take all that information and make our selection for cohort 2 in March of 2025. Once we make that selection, we will reach out to obviously the FQHCs that applied and were accepted, and the MCPs that would be affiliated with those FQHCs to bring you into our meeting series that we have with the MCPs and FQHCs on a bi-weekly basis. Going to our next piece, all intermittent clinic change of ownerships must be finalized by May 30th of 2025. This would be if you an organization has bought outside clinics and is rolling them under one of the parent sites that have applied for the program. So if you have purchased a new facility after the application period and that facility is going to be a parent site, they would not be automatically eligible to be in the program because they would have missed all of the information that we request as part of the application process. So adding new sites has to be as part of the application process and not able to become in during the middle of a program year, except for intermittent clinics, which can roll under a parent that's in the program, as long as it happens within the time frame where we are able to adjust the rates and it meets all of the criteria for having a new or transferring intermittent clinic. June 1st, we will be releasing the draft APM, PMPMs, the per member per month rates for each of the eligible cohort 2 facilities. And then by July 1st, the FQHC, once they've seen their rate as of June 1st, must make their selection for participation in the 1125 cohort, or 1126 cohort, sorry, which we're calling cohort 2. There's a whole list of readiness activities that are required from the FQHCs and the MCPs, which will be due or required to be completed in August of 2025. Last day for withdrawal from the APM would be September 3rd. And so that, if a cohort 1 participant wanted to withdraw, this allows us the time necessarily to remove the rate development from the managed care plans rates that we would work on if they do have a participating FQHC. We would then have the FQHCs and MCPs begin testing coding or any data sharing needs in September of 2025, with the attestations being due for all readiness activities on November 3rd, and a go live date for cohort 2 in January 1 of 2026. One thing we don't have listed but would be in this November range would be the final per member per month rates. If you can see up here, June 1st releasing the draft rates. There could be some slight actuarial adjustments, but where the real big change would be the MEI release in October, which would allow us to finalize the rates that were being developed for the program. So that would be sometime end of October, early November. And then there are two that's the timeline. And I'll be sharing all of this documentation after with all the registered attendees. I'll send it through an email, and then I will also get it posted to the web. And then we're recording this, and it will also go to the web in the near future. Two forms that must be submitted is the application spreadsheet form and the health plan roster assessment. So the spreadsheet is really just a walkthrough, and it shows us, and we'll kind of go through it a little bit, but just shows all of the structure that you're applying for. So parent sites, NPIs, intermittent clinics attached to those, estimated membership or assignment at those sites as well. Getting down to the eligibility to apply to participate. So FQHCs, FQHC lookalikes, and qualifying tribal entities may apply to participate in the APM. We'll kind of skip through some of the more dry statutory requirements, but those are available here that show, exactly what we're defining as the ability to participate. So you can see the definition of WIC 14138.1I states an FQHC means any community or public federally qualified health center is defined in the section of 42 CFR and then other sections. So we can kind of skip through that, but please, before you apply, make sure that you meet all of the qualifications. Now to talk a little bit about how we will select and the readiness to participate. So today we are opening the application process for interested FQHCs for our January 1, 2026 start date. The intended participation goal is to have a variety of FQHCs participate, including a blend of urban, rural, large, and small facilities. FQHCs will apply to DHCS to participate in the APM. And then all sites under each PPS in a participating FQHC must participate, including mobile units/sites and intermittent sites associated with the billing NPI PPS rate, even if that intermittent clinic or mobile site is independently licensed, if applicable. So if you have a site that has a $250 PPS rate, and then it has 3 associated intermittent clinics, you're applying for that parent and the 3 associated intermittent clinics, not for the parent and 1 of the intermittent clinics. So that's one key thing to think about when you go to apply for the program. Once selected, the FQHCs may not modify the parent, intermittent, and mobile unit/site structure associated with the APM NPI after applying to get into the APM without specific adjustment to the capitated rate. To have actually sound managed care rates, there must be sufficient data for the actuary to match the baseline data to the APM structure, i.e. intermittent sites and mobile units/sites in the baseline year should be associated with the same parent billing NPI under the APM. So kind of dive down a little bit deeper into that specific request or requirement. If you're applying, let's say you have 2 parent sites with 2 intermittent clinics under each of them, and you apply in that manner. If you were to move one of your intermittent clinics from one parent site to the other, without us, DHCS, being able to appropriately adjust the data, the APM PMs that would be developed under the 1 parent with 2 intermittent and 1 parent with 2 intermittent structures would not be valid for the structure of 1 parent with 1 intermittent and 1 parent with 3 intermittents. So DHCS needs to have enough information to be able to adjust the utilization to match the base year to the program year that the site would be participating in. So as part of your application, if you know that, so the base year for this program is 23-20, state fiscal year 23-24 for calendar year 2026. So if you know that there's been a change in your structure from 23-24 to 1-1-26 or current, if that's the case, then that will be needed on your application. So we need to know how things were set up back then and how they are today. And that's one of the big pieces in order to set rates, is to have that alignment between the application structure and the actual structure in practice. Someone, let me go ahead, Fernando. You should be able to unmute yourself now.
No, I'm not sure that reflecting those changes in the application is going to facilitate the calculation or the development of the appropriate rates, so long as DHCS doesn't have the ability to identify the intermittent clinic encounters and enrollment data. Because we can we can advise the department within the application that in the scenario you gave where you have two parents and then, two intermittent clinics, and in the application say, I'm changing from, from 2 and 2 to 3 to 1, and advise you in the application. But if you don't have the ability to then identify that encounter data and the enrollment data, then how
So
how are we going
just being able to tell us that you are doing the change doesn't mean the change is going to be, it doesn't mean we are going to be able to set a rate.
yeah,
But
and that's what I'm trying to
yeah,
get to, is that
yeah. So
yeah,
it's not a specific, if you do this, then you're guaranteed in. It's just that if you don't do that, then you're definitely not guaranteed in. Does that make sense? Like
yeah, no, it,
we,
it does, but I think maybe you want to think about how you
yeah. Oh,
modify
there's
this
yeah.
language to,
No, there's a
yeah,
lot there. Yeah, there's more that we're going to get to, and
yeah,
there's a lot more in the application. So this is really just a high level overview,
okay,
kind of talking through it. So
yeah, okay, fair enough, thank you.
yeah, no problem. So in relation to the application, DHCS will attempt to ensure interested applicants are notified of deadlines with sufficient time to complete the application, which is continuously posted on the DHCS website. So our new application documents will be going up in the next week or so, and then those will be up there for everyone to review, even after the process, so that if you're thinking about for cohort 3 or future cohorts, you'll have some information. It may be slight updates as we move forward, and really, it's a living process as we try to get better and provide more clarity and a smoother process. We will be reviewing all of the applications, and to be considered for participation in the NPM, the site must submit a complete application with all required elements and must be deemed to have complete responsive narratives on all of the criteria listed below and in the state's approved state plan amendment with the Centers for Medicare and Medicaid Services, which is currently going through the process of being approved for our July 1st, 2024, which we have called our cohort 1A. In its sole discretion, DHCS shall select FQHCs that have applied for participation in the APM program for a particular calendar year based on the following standards, which demonstrate operational, clinical, data, and financial readiness to participate in the APM in the following manner. Complete application and commitment to APM. The FQHC has submitted a complete written application, including a letter of support from applying FQHC's CEO or designees, attesting to the following: commitment to the APM care transformation strategy, willingness to commit staff participation in quality collaborative learning communities, organizational commitment to creating and maintaining an effective quality improvement infrastructure, organizational commitments to redesigning the FQHC's care team to improve quality of care outcomes, encounter data / fee for service, RAT claim match, and percentage of assigned encounter data. So FQHCs must meet a minimum benchmark of at least 66% of RAP records, having a corresponding encounter record to determine the data viability for participation in the APM. Only FQHCs with a match rate exceeding this threshold are admitted to the APM. So a little bit more about that. The reason for this kind of demarcation line is that the APM provides a requirement as dictated by CMS that we make sure the participants receive at minimum their PPS rate times the utilization eligible for PPS rate. So at the end of every program period, we will be looking at the amount of APM PMPM dollars you received and comparing that to the amount of PPS visits that you had in that particular year, ensuring that if your APM PMPMs were to reimburse you below a level of what you would have received had you been billing for PPS, that we will pay you up to that amount. So there's that minimum threshold for FQHCs to always receive PPS. And in our application process, we look at this RAP encounters, which we assume to be the most accurate view of the FQHC's data, because you submit it and you receive a PPS payment. So that is what we're considering kind of the baseline, versus the managed care data is what comes up through your managed care plans for the same encounters and may not always align. If we do not see that alignment, we can't trust that the data for when you are in the program, once you are no longer submitting RAP claims to us, to DHCS, we will have an accurate view of your actual PPS rates for the reconciliation, or for the PPS encounters for the reconciliation process. So it's really a fail-safe for the FQHCs and to protect your time and investment in this program. One thing that is different for this period is that we are currently working on a public-facing dashboard that would allow you to input your NPI, and it would show you your RAP claim to encounter comparison. That unfortunately is not ready for public yet. Instead, we've kind of put together this process where the FQHCs can email our inbox at FQHC APM at dhcs.ca.gov and request their percentage. I will say that the response time may vary. If I have we have 1,000 requests, it might take a little bit longer to get to all of them. If we have 10, it's probably going to be a little bit quicker turnaround. The request must include the clinic name, the NPI, and identification as a parent or intermittent clinic. So we need to be able to roll those up to kind of show you your total mass percentage for consider the parent site as a holistic piece. Another piece is the assigned utilization. So FQHCs must have at least 50% of reported MCP encounters incurred by assigned APM enrollees, demonstrating a commitment to medical home models of care and ensuring an actually sound MCP capitated rate can be calculated by the state's actuary for the MCP with APM contracted FQHCs. This is really to, because we can only pay you on assigned members, that if your utilization is too high for unassigned members, we would not be able to set an actuarially sound rate. For FQHCs that fall between 50 and 70% of the assigned utilization, we will be modifying the rate to match 70% and be at a level which we feel comfortable to set that rate. So there can be adjustments if you are between 50 and 70% of your utilization coming from assigned members. Data capabilities. The FQHC has appropriate data capabilities, including the ability to submit complete, timely, and compliant encounter data, including data reflecting non-PPS eligible services addressing health-related social needs, which we would consider are Q2 modifiers for alternative services, which are part of the program. In the package that I send out for this, including all the application documents, I will include a copy of the program guide, which you can review for more information. In addition, the FQHC demonstrates an ability to internally track data for all APM quality metrics and to interface with various portals, thereby enabling the sharing of quality data to health plans. Capacity for care transformation, the APM strategy. The FQHC has outlined at least a 5-year strategy for participation in the APM to transform its care delivery model and improve quality and health equity, and envisions expanding the APM to all sites. Transformation, our care transformation, experience with strategic practice transformation. The FQHC has documented at least 3 goals for strategic practice transformation and outlined how participation on the APM will help the FQHC achieve those goals. The FQHC has documented previous experiences and successes with strategic practice transformation. Staffing capacity to enact transformation. The FQHC has documented and justified its current care team model and staffing ratios. The FQHC has outlined a plan to modify its care team model and staffing ratios in the next 5 years to achieve APM practice transformation strategic goals. The FQHC has identified potential challenges in achieving the necessary staffing and how to overcome those challenges. Quality improvement infrastructure. The FQHC system has a formal quality improvement infrastructure to improve healthcare effectiveness data and information set. UDIS/Uniform Data System, UDS, or other quality measures including clinical staff, methods used, data integration methods, and evaluation of the quality improvement infrastructure. The FQHC has a formal plan for meeting the quality improvement targets and its 3 top care transformation goals, including lessons learned from past relevant successes. The FQHC has identified potential challenges in achieving continuous quality improvement. So I think just in sake of time, kind of just hit the highlights for the rest of these. So collaboration and care with the MCPs. So how you're working with your MCP contractors to achieve the goals. Financial and administrative capacity to undertake. Like, are you financially healthy enough to deal with the kind of change to your reimbursement structure? Operational considerations, your contracting, make sure that data readiness is there and that you're in good standing with your partners, and commitment to the APM, that you're in good standing with state and federal regulators, and if the FQHC reassigns an intermittent site to a different parent site, MPI subsequent to the base period, the MPI of both parents shall be excluded. So that's kind of talking about if you're moving your sites around and we don't know or can't identify, then we cannot have a solid base for which to set your rates. One of the pieces here is that in order to be eligible to participate, the FQHC must agree to forego reassignment of intermittent sites mobile units under the APM during an active rating period. So that any changes must be identified at least 180 days in advance of the next rating period, so that data associated with the intermittent sites can be identified, and so it must be identified to be able to move that from the old parent site and to match the new structure. A participating FQHC may choose to remove a particular MPI from the APM so long as notice is provided to DHCS no less than 100 days before the beginning of the next managed care rating period. So for example, if you went live on 1/1/26 and within the first few months you realize that you do not want to continue participating for 1/1/27, we would be requesting that you let us know 180 days in advance of 1/1/27 that you would no longer like to participate in the program. In its sole discretion, DHCS may exclude FQHCs for which actually appropriate rates cannot be calculated in accordance with the SPA. So that relates to if there are changes that are not known but happen, and then that changes what should have been developed for your program or for the program for your facilities, we could exclude that site. DHCS may choose to remove the MPI from participation in the APM for a participating FQHC in the event DHCS cannot establish a unique APM PMPM for a parent site or an actually sound capitation rate for the MCP for any reasons, including but not limited to the utilization data in the base year from intermittent sites / mobile units no longer in the MPI cannot be accurately identified and isolated. The utilization in the base year from an intermittent site / mobile unit added to the MPI cannot be accurately removed from another parent site, and the historic claims of an intermittent site / mobile unit were not submitted to the MCP or DHCS, and the base year does not reflect the utilization data of an existing or ongoing intermittent site mobile site. So anything that jeopardizes the connection between the base year data and the program year can lead to that NPI not being able to participate in the APM. Selected and participating FQHCs, as well as the MCPs with which they contract, must supply DHCS with sufficient information for the development of actuarially sound Medi-Cal MCP rates. At a minimum, participating FQHCs and MCPs must submit the following information to DHCS for the development of a unique APM PMPM in the timing and manner determined by DHCS. So identification and documentation of the participating FQHC's contracts for Medi-Cal program services with MCPs. A reasonable estimate of the number of enrollees assigned to the participating FQHC by each contracted Medi-Cal MCP by NPI number, with MCPs submitting the actual member rosters for the base year for the participating FQHCs to DHCS, and the PPS rate for the participating FQHC by NPI number. Any decision to exclude or remove an FQHC MPI or imminent site mobile unit for participation in APM or an APM PM rate development shall require DHCS to notify the FQHC. If this notification occurs after the APM withdrawal deadline, the FQHC will have 30 days from the date of the notification to withdraw from the APM. If any information for rate development is unavailable and DHCS is unable to establish a unique APM PM rate for a particular NPI associated with participating FQHC, then such NPI will be excluded from participating in the APM. For an NPI to participate in the APM, the participating FQHC and its contracted MCPs must supply DHCS with following information in the time and manner determined by DHCS. And so the data must meet quality data standards of at least 66% match rate and have at least 50% encounters from assigned APM enrollees. The MPI must have clean base year utilization data for the site sufficient to be able to set an APM PM rate and the associated MCP capitation rate, i.e. the structure of the parent site and its intermittent sites must match the proposal under the APM. The MPI cannot have any change in the licensure structure of the parent or its intermittent site / mobile units after the application through the end of the APM year. Any change in the structure must be called out in the application or at least 180 days in advance and must include specific changes to be made, and the data must be identifiable to be able to be moved to match the new structure effective with the beginning of the next CY. And these conditions do not preclude a parent site from establishing a new intermittent / mobile unit starting with no base year utilization, so long as the FQHC provides enough utilization information for the state's actuary to set actually sound rates. Go ahead, Fernando.
Yeah, Nick, just in this section, if you can scroll back up. So this whole section implies that an FQHC can submit supplemental data. That's my interpretation of this whole section. It doesn't say, it uses the word validate or identifiable, but identifiable by who? The FQHC, can identify that data.
So the FQHC does submit data to the MCP, which then submits it to DHCS. So if I can throw in they're not specifically directly from the FQHC, but we consider that the FQHC is partnering with the MCP to submit those encounters as part of the process, which we would then use to identify the rest of the information. So I can add some more language if that makes it clearer, but that's kind of what we're implying with the FQHC and the MCP working together to have this data submitted.
Okay, but that's in the first bullet point. I was just referencing to this entire section because there's references in here to identifiable. Let's see, on the second paragraph, says specific changes to be made and the data must be identifiable to be able to be moved to match the new structure. Identifiable, again, I can identify the encounter data and the enrollment data that relates to the new match, right? I can identify it. So if this implies that I can provide data to DHCS and Mercer that identifies the encounter data and the enrollment data that should be utilized to set the rate. That is my interpretation of this entire section.
Okay, so I will clarify that is not our interpretation nor meaning behind it. So I will make sure to add a couple things in there before this gets sent out.
Okay.
It's more of that we expect them to be identifiable in our systems from the MCP.
Yeah.
Or what is in the DHCS system. So I'll make sure that that lines up better.
Got it. Okay. Thanks, Nick.
Yeah, no problem. So here's a little bit more information on the ability to leave the APM. Kind of what we talked to is the year September 1st, the year prior, start of the contract year, and then that's for any site participating for the first time, and then as we go forward, if someone is in the APM, so subsequently annual opt-out for MCPs must occur within 180 days prior to start. That has to do with the timing for DHCS to submit our rates to CMS and make sure everything is applicable there. It talks a little bit about our process for changing scopes. Like I said, this will be kind of sent out, so you can kind of dive more in there. Always feel free to send me any questions. We will be using encounter only data. So this is kind of what I was talking about earlier. And so if we don't have accurate encounter data submitted by the MCPs, it is something that will preclude us from really being able to confirm with CMS that we are guaranteeing the FQHC is receiving at least PPS. So it's one of those things where we want to respect the kind of APM program, and that it guarantees PPS, and that we're not harming the FQHCs for kind of taking that next step here with us in this kind of new program, and not putting anything else at risk. That's that 66% RAP record threshold. And so, feel free to reach out and we can provide you with a preview of your RAP percentage before applying. Kind of scrolling through here, a little bit more about the encounter threshold. Like I said earlier, if you have more than 30% unassigned, if you have 1,000 visits and more than 30% of those visits are from unassigned members, we will adjust the total utilization used in the APM PMPM calculation to reach that 70% assigned versus 30% unassigned. If your FQHC site has more than 50% unassigned, then we will not be allowing that into the program. There are many reasons that these mismatches can happen. I've seen all sorts of different options, and so there's nothing that at this point in the Medi-Cal world where that this RAP percentage has been something that's been crucial. So it may take time. You may be below that threshold for this year, but it's definitely something that you can work with your MCP on, and we're happy to kind of make those connections. We've seen where NPIs are being reported wrong by a clearinghouse. There's all sorts of different issues that could happen there. This kind of just does a deeper dive of what we're actually doing for that match. So you can read through that. We don't need to go through the specifics. Talks about what specifically we're looking at. So we're only looking at the eligible population of APM members, as well as the eligible data for the APM. So we can kind of skip through there, and then we'll kind of just hit these last 15 minutes. Actually, we'll go a little bit fast on that. So I'll just kind of breeze through the specifics here. Feel free to spend your time reviewing them, but want to leave a couple minutes at the end in case there's any more questions. So these are all divided up into different sections. So the first one is going to be that spreadsheet attachment, which is linked in the document. And that really just talks about what we're looking for. So defining our base year period, what we're considering, the billing NPIs, talking about your intermittent clinics. If you have an interim rate, we're treating it just like it is for the APM. I'll also be sending the program guide, which is a long document that talks about all of these things, more of the individual items. It does not yet have the updated information for the application, but it does talk, that'll be coming soon. It does talk through all of these kind of pieces around how interim sites are treated, how the reconciliation process works. MCPs must assign by members, by MPI or PPS site if they're not doing so already. Give some examples of how that needs to be filled out. Data capability, and you will also see, I guess one other thing to point out, kind of here on the back end, some of this is for members of cohort 1A or 1B if they're looking to add additional NPIs or make changes they only fill out partials, and then for cohort 2 they'll submit entirely. The narrative portions as we get here, section 2 for cohort 2 only. So really, describe the data quality requirements and standards, how you guys fit into them. It's really, it's a narrative portion of the application. So feel free to look through those. Section 3 is additional items for submission. So it'll kind of check off these boxes to make sure that you're really hitting all of the pieces. Section 4 is talking about your APM strategy for how you envision your site or your organization and what the APM, what you're going to do for that over the next 5 years. Experience with strategic practice transformation, a couple more additional items for cohort 2, talking about your staffing capacity, the quality improvement infrastructure, how you collaborate with MCPs, just double checking to make sure you have all of your attachments and stuff turned in. Keep going. We have section 11, which is talking about your financial standing. So these are all, talks about here, the narratives portions, what you need to include for that piece. And then finally, the last one is the organizational commitment to transforming primary practice, which will include a letter of support from the CEO or the CEO designee attesting to the items. And then here is, kind of where everything should be addressed to and sent in. So that is the end of this document. That was a lot of information. I'll just scroll back up here to the top. We're going to be sending those out today, like I said, and also posting them to the website. Just to reiterate that December 16th is the deadline for the applications to be submitted. And then we will be in contact in January after we've had a chance to review and set up times to talk to your organization. Looking to have all of this decided in March. And then, giving you guys the opportunity to, essentially we're accepting you into the APM, setting rates, and then once we provide those draft rates, the participants will decide whether or not they want to go live as of 1/1/26 or wait for another program year to happen. So questions, I'll open up. If you raise your hand, I can unmute you, or you could ask it in the chat. And if there are no questions, we can end there. So I'll give it a 30 seconds, see if anybody has any questions. Question in the chat from Angelica. For participants in cohort 1A, how are you capturing the encounters with T1015? So do you mean for those that are live as of now? So the T1015 claims are no longer submitted. They would be submitting their regular, that's the fee for service designation to get the RAP payment, so managed care RAP differential. In managed care, they're just submitting their encounters like normal, and yeah. So then we're looking at essentially all of those, all of the data submitted by the MCP and looking for Q2 modifiers for anything that's an alternative. I see Jennifer. There you go. You should be able to unmute Jennifer.
Nick, can you hear me?
Yep.
Okay, great. Two different questions. One, can you remind me if there are any specific population or benefit carve-outs. So I believe it was dual eligibles originally.
Yes, so all dual eligibles, and I think I have it in here somewhere, but I'm probably not gonna be able to find it on the fly. So dental claims are excluded.
Okay.
Dual eligibles, what we would call like I'm trying blanking on the word. The Medi-Cal members who are not yet fully enrolled, presumptive eligibility, and CBAS. It's in the program guide. It's like a long list, but yeah. So in general,
Okay.
population would be like a emergency Medi-Cal, dual eligibles. I think there's something else like pregnancy related. I believe in some situations would be excluded, but we have a more exhaustive list in the program guide.
Okay, if it's in the guide, I can take a look at that. And then dental is excluded. We're in a dental integration county, so that is out.
Yes.
Okay. And then how about we have some multi-specialties at our FQs. All specialties are in, I'm assuming, if it's part of the FQ scope.
Yes.
And then separate topic on the, I believe you're calling it the threshold, the 66% threshold.
Yes.
Is that representative of what you saw in cohort 1? I'm just wondering.
Yeah, it was
Where that
so.
came from.
Yeah, it was kind of a key demarcation between what we saw as like good data practices versus not. And I shouldn't say bad data practices. There were situations that were, I wouldn't say that all the situations were within control of the organizations, whether it's the MCP or the FQHC, but not something that we actually like that you would actually be expected to kind of work with on a regular basis. For example, there was we had a clinic where the clearinghouse was just using a generic, or not a generic, but an older NPI, and so the FQHC submits it to clearinghouse. The clearinghouse was changing it, and the MCP is not seeing it as anything wrong. But when we go to match that wrapping counter submitted by the FQHC to what's submitted by the managed care plan, they just weren't aligned. So that's kind of why we were like we've kind of created this request and hopefully within the next month or so have a dashboard available, so clinics can really see and say, oh, it is the data that I'm submitting as part of my wrap claim matching what the MCP is eventually transmitting to DHCS. And so that 66% was like the clean break line from that cohort 1, and so we've kept it at that level. It looks like it muted you again, but
Yeah, that's
Yep, there you go.
fine. That was helpful. And then I guess last question, it may be premature. I believe this is the first year for cohort 1, but are there learnings from year 1 that you will be sharing?
I mean, we will eventually. It's still too early to really give any conclusions. I mean, we definitely have some best practices that we've implemented for this application process to help provide a smoother process in general. I will say the biggest piece is really the assignment and complete encounter data. So are your assignments pretty well balanced with the like do you have the same data that the MCP has, right? So a lot of the things that I think I would say that I would recommend as like a general things to improve on are making sure that the rosters that are provided by the MCPs are something that the FQHC is looking at consistently, and that the data that you're submitting to for your T1015 claims are the same thing that you're submitting to the MCPs, right? So making sure that data's in alignment. And we've made a lot of adjustments to our program guide over the last 2 years, as well as the application process that kind of reflect a lot of our best practices. And we're hoping to have start getting the encounter data soon from our 1A clinics and really making sure that what they're submitting is what we're seeing, and kind of working through a best practices for once sites start participating in the APM. And then any other questions? I don't know, Jennifer, if you had anything else.
I'm good, thank you.
All right, thanks. All right, well then, with that, we can, oh, I see we have another hand up. Go ahead, Ricardo. You can unmute, you still have to unmute yourself, but you should be able to do it now.
Well, Nicholas, can you hear me?
Oh, yes, I can hear you now.
Okay. How about mental health? I'm not sure if I caught it or not. Will they be able to participate in this?
We do have, I mean, I can't quote it off the top of my head, but there are some mental health services included in the program and some are excluded. So behavioral health, I think it's mild, moderate mental health is included in the program.
Oh, I see. Okay, thank you.
No problem. Like I said, I'll attach our prior version of the guide that will, if you have any more like specific detailed technical questions, that should be able to answer for you. All right, last call. All right, well, thank you everybody for attending today. And just to reiterate, for anybody that registered, I will be emailing out the application documentation. We'll get that posted to the website as well as a copy of this webinar. So hope you all have a great rest of your day and look forward to working with you all in the near future.